Greetings, I'm Dr. Gayatri Acharya, Cardiology Fellow at Mayo Clinic. During today's roundtable, we'll be discussing cardiac amyloidosis. I'm joined by my colleagues Dr. Martha Grogan and Dr. Omar Abou Ezzeddine, who both specialize in this area. Welcome.
Thank you.
Let's start by talking about cardiac amyloidosis in general. What clinical characteristics make you suspicious for this when you see a patient? Dr. Grogan?
Many times in cardiology we'll come to the suspicion of amyloidosis based on imaging or unexplained heart failure, unexplained atrial arrhythmias. But I would say for many cardiologists, the first suspicion is going to be imaging, either an echo or an MRI, that's going to make them suspicious of amyloidosis.
Okay. In addition to imaging findings, Dr. Abou Ezzeddine, what clinical characteristics, physical exam findings would make you concerned?
Sure. So physical exam findings are the classic heart failure exam findings. So typically right-sided symptoms of JVP elevation, lower extremity edema, abdominal distension, ascites, hepatomegaly, things like this, as well as findings of pulmonary hypertension. You can have an accentuated second heart sound, for instance, a right-sided S4. But you can also obviously have left-sided symptoms with elevated left-sided filling pressure, such as pulmonary edema, etc. And a physical examination finding that we sometimes miss as cardiologists is macroglossia. And that's something that you need to look for to really find. On history, typically we ask questions that are not classic cardiac clinical questions, such as a history of, for example, carpal tunnel syndrome or spinal stenosis in more of our elderly patients, because they have also been associated with diagnosis of cardiac amyloidosis. On imaging, typically on an ECG, you could find low voltage. However, caution, that's only present in around 30% of patients or so, more so in hereditary transthyretin cardiac amyloidosis, or AL. But you can also have LVH signs on the ECG, atrial arrhythmias, or conduction system disease as well. Echocardiography, typically classic is a restrictive cardiomyopathy appearing morphology with increased wall thickness, again more so in TTR compared to AL, but it can occur in both, and biatrial enlargement, diastolic dysfunction, and restrictive filling. Those are the main findings that general cardiologists may come across clinically.
And that raises your initial suspicion of amyloid. Dr. Grogan, how do we now, once we reach the thought of amyloid, decide between AL and TTR? Are there differences we can tell?
That's a great question, because as I mentioned, many times cardiologists kind of come into the diagnosis because of an imaging abnormality, although all the things that Dr. Abou Ezzeddine just mentioned are really important clinically. Having said that, so once we have the constellation of imaging findings and some clinical findings, really we cannot guess at which type of amyloid. So if you look at echo, MRI, those tests, it's very dangerous to try to say this one is AL, this one is TTR. The TTR patients tend to have even thicker hearts and sometimes are more well compensated, but we really have to get to the specific diagnosis. So the key thing for cardiologists to remember is if you're making a diagnosis of AL amyloid, you always have to have tissue. You have to have a tissue biopsy either from the heart or from another organ or the fat. And then we recommend typing with mass spectrometry because that is the most accurate. So having a good pathologist, not all pathologists are used to looking for amyloid or staining properly, so if you get a negative result, continue to pursue, send the pathology for review. But for AL, you always have to have tissue. For TTR amyloid, as Omar is going to tell us, PYP scan can be used if AL amyloid has been excluded with a screen test for AL or negative.
And at what point do you consider the PYP scan?
It depends on obviously the facility and your resources, but here at Mayo we typically get that early on as a diagnostic test after when you're working up a patient for amyloid. But caution, you really have to have drawn the blood, checked for monoclonal protein, free light chains, to make sure that you're not missing that diagnosis, and you cannot interpret a pyrophosphate scan, which we'll talk more about, without having ruled out monoclonal disease. Because
yeah, and just to make it clear for people, because a lot of times when we talk about it, people say, do I really have to get this test or that test? It's not that hard. So serum-free light chains, they're universally available, they're inexpensive. Then serum protein electrophoresis with immunofixation. That'll be the most common way you'll hear it termed, but just make sure it's serum with immunofixation and then urine with immunofixation. Do those three things, learn what they are, and get them down. We're seeing that a TTR amyloid is really not rare, especially wild-type TTR amyloid, but up to 40% of those patients will have monoclonal gammopathy, especially because that's common as people get older. So really important for cardiologists to learn these tests. Quit bugging me about, do we need to get them? Yes, you need to get them. But then if they're negative, you can use the PYP alone. I often still use a PYP even early on, because if it's negative, it supports even more if everything else is pointing to AL. And occasionally, with AL patients, they can deteriorate very, very quickly. So we want to get to the diagnosis as fast as possible. So I even use a PYP in a negative sense.
And Dr. Abou Ezzeddine, can you explain for us what a PYP scan is and what the strengths and limitations of that test are?
Sure. Actually, PYP stands for pyrophosphate, and that's the tracer that we use here in North America that's FDA approved for bone scans, actually. So it's a bone tracer that has been previously described in the 80s as a potential screening tool for cardiac amyloidosis, because patients with amyloid were noted to have myocardial uptake with this bone tracer. And so, however, that technology back then was not pursued because it was noted that some patients with amyloid didn't have positive scans. And we think that's probably because those were probably light chain amyloidosis patients rather than transthyretin cardiac amyloid patients. And more recently, in the early 2000s, Dr. Rapezzi's group out in Italy did a landmark study where they looked at patients with TTR, cardiac amyloid, AL, and controls, and what they found was there's indeed myocardial uptake in TTR much more significantly, if you want, compared to ALs and controls. Now, they used a bone tracer called DPD, which is not FDA approved for use in the United States, which is why we use pyrophosphate scans here. So some limitations of planar imaging with pyrophosphate scans is it's essentially a planar image is a 2D X-ray-like image of the chest cavity. And so, and we look at myocardial uptake either in a semi-quantitative fashion compared to bone uptake, or in a quantitative fashion as described initially by Maurer et al. At Columbia, where we look at myocardial uptake in the heart over the contralateral chest ratio of uptake. And that is thought to standardize or normalize for bone and soft tissue uptake. And if that H to CL ratio, or heart to contralateral, is over a certain threshold, then it's believed to be diagnostic for cardiac amyloidosis with a specificity that approaches 100%. Once, again, a caveat, you have ruled out light chain amyloidosis. And so that essentially gets rid of the need for a cardiac biopsy, which is quite practice changing. But it's very important that the limitations of pyrophosphate scan be considered, and that is ruling out light chain amyloidosis and making sure once you're doing this scan that you're not facing a case of a falsely elevated H to CL ratio, such as if there are any bone fractures in that territory. It's a bone tracer, and so that can falsely elevate your H to CL ratio. Other things in that anything in your chest cavity on that side, such as mitral annular calcification, aortic stenosis that's severely calcified, lung nodules, etc., and even breast tissue can again falsely elevate that ratio. So you really have to be very rigorous in interpreting a pyrophosphate scan.
And Dr. Grogan, do we have standardized cutoffs for these ratios that we should be using? And what do you do with equivocal results?
Yeah, that's a great question, because many centers use imaging at 1 hour. Our center and some others use 3-hour imaging. So the cutoff will depend on your institution, what you have set as your cutoff. So ours will be 1.3 for the H, the heart to contralateral ratio. But that's very important. People will sometimes call us up and say, oh, I have a person, they had this positive PYP scan, here's the ratio. And when we ask the practitioner, well, when was the patient imaged, they don't know. So the protocol is really important. As far as when we have maybe seen false positives, we have seen one patient with plaquenil cardiotoxicity who had a positive PYP. And then went on to have a biopsy. And there were a couple others that were suspicious too, but one very definite one. I think we have to remember that the original papers, or all the data so far, has been in patients who had a high pretest likelihood of having amyloidosis, mostly a high pretest likelihood of TTR amyloid, but also of AL. So could there be other cardiac conditions? You know, it's possible. So it's a new test. We all have to take that with a grain of salt. Having said that, we have the consensus guidelines that we've just kind of highlighted, that if your screening for AL is negative, currently and if you have a typical echo and or MRI. So that's another important thing, not just indiscriminate screening of patients with PYP, but the typical echo features, thickened walls, usually abnormal strain, restrictive filling, that kind of thing, or MRI findings. So if you put those together, it is a very good test. Some people will say, well, gosh, you're still going to have those patients with monoclonal protein, and I'm still going to have to get tissue. But that is, you know, maybe 40%, you know, you still have at least 40 to 60% where you won't need a heart biopsy, whereas previously 85% of these patients needed a heart biopsy. So it really has revolutionized our ability to make this diagnosis.
And making things as non-invasive as possible, I think, is always going to be the safer option for our patients.
And then one crucial thing, it is well known that AL amyloidosis can have uptake on PYP. And we've recently even seen patients with pretty strong grade 3 uptake or more. So just make sure that you know that you need to get tissue if those AL screening tests are abnormal, because you do not want to make the mistake of thinking the patient has TTR amyloid when they have AL. The treatment will be completely different. And you don't want to delay chemotherapy because you've made that mistake.
I wanted to also tag on to Dr. Grogan's response as far as when you have equivocal planar imaging. What we have been doing here at Mayo is doing concomitant SPECT-CT imaging to specifically look at the myocardium, the morphology of the myocardium, and where that uptake is. Is it indeed in the myocardium? Is it in the blood pool? And we're increasingly seeing cases that are positive on the planar imaging, on the H to CL ratio, and then when you actually look at the SPECT-CT and looking at the myocardium itself, the uptake is all blood pool, or you're capturing, again, calcified valves or whatnot. And so, or a rib fracture, for example, we see those quite commonly, actually, in the nuclear lab as well. So it's an important addition, I think, to the approach that has been initially described with planar imaging.
Another thing that we sometimes forget to talk about is that PYP previously was used to grade the size of myocardial infarction. So if a patient has had a recent myocardial infarction, then PYP is going to light up in that area. It's quite easy, even for those who do not interpret PYP scans, to learn to read them, and it's pretty simple to look at those SPECT images and see if you see it lighting up. Is it lighting up diffusely? So very good. Also, if you're really unsure, then get a heart biopsy.
Yeah, and we typically wait around 4 weeks after a myocardial infarction to image the patient. It's thought the activity sort of abates after the 4-week cut point.
So when you have an unequivocal positive PYP scan, what's the next step for our patients?
So for us in the cardiac amyloid clinic, our next step is they have this diagnosis, again, once you've ruled out light chain because of prognostic and therapeutic consequences, to proceed with genetic testing. And yes, the patient may be elderly or what we think is elderly, but they do have children that are not. And if this is a hereditary process that we're missing, then we're not doing our due diligence as providers. So our typical approach is we sequence the TTR gene and look for any mutations that would explain that diagnosis.
And that has come down in cost considerably. Whenever you ask about cost, you'll get different numbers, but still, it's not a very, very expensive test as it would have been in the past. There are complementary programs through some of the various industry sponsors too, if a person really couldn't afford the testing. But it just really, we just need to get it in everyone. Because even in the mid-80s, we've seen patients at 85 years old who have a pathogenic mutation. So one could argue how much of a role did it play in that patient, but now we know they have that and their children are at increased risk of amyloid and need to be at least considered genetic testing.
What's required to perform a PYP scan, and what would the time commitment for a patient be if you're referring someone and they ask you, how do you best answer that?
So any nuclear lab that's performing stress testing or has access to a technetium generator, that's all you need from a radiotracer standpoint. A SPECT CT camera is what we have here, and essentially our protocol at Mayo, again, a bit different than other places in that we do imaging not only at baseline, or at 15 minutes, and that's typically a 5-minute scan after injecting the pyrophosphate, but also at 3 hours, and that's typically a longer. SPECT CT scan is around 40 to 45 minutes long. However, if you're doing just planar imaging, it's much shorter than that. We typically have patients present, get the isotope, image at 15 minutes, and then they come back at the 3-hour time point for their 3-hour imaging. And it's the 3-hour imaging that we really use here to confirm or rule out myocardial uptake of pyrophosphate. Yes.
Is it useful to receive scans from an outside institution? Are those able to be interpreted easily for continuing tertiary care?
It's an excellent question, and in the ideal world, the answer is yes, but many times the imaging comes, we don't know what the protocol that was used, we don't know how much isotope was used, what the protocol that was used at that center was. It may be, but there's countless times where I've needed to repeat imaging here because of the image quality or whatnot. Yeah, because we don't have full access to its data that's provided. We cannot actually modify it a lot of the times, not modify, but sort of reinterpret it using our software per se. Potentially down the line, yes.
And I think it's fairly easy to assess that. So we have patients now, again, as people are starting up this imaging, people are at different points in their own laboratory of how comfortable they are, how much they've set up their protocol. But we're starting to see more where you'll get the images, you have the report, you know the sequence, and if it's all positive, you really don't necessarily need to repeat it. So I think we'll start to see a little more standardization of that.
And Dr. Grogan, what's next for our patients with TTR amyloidosis? What options do we have in the future?
It's a really exciting time. We'll have to have another video, I think, to talk about treatment. But as many people may know, for years, wild-type TTR particularly was considered, many would say it's an academic disease. Why are you even looking for it? We used to call it senile systemic amyloidosis, but now our youngest patient here at Mayo was 47 years old, so we got rid of that. So we know it can occur in younger patients. So now we have a variety of options that are just emerging both for wild type and hereditary patients with cardiac involvement. Tafamidis is a TTR stabilizer and has been shown to reduce mortality and cardiovascular hospitalization in patients with TTR involvement, with cardiac involvement. And then there are new drugs, RNA interfering drugs that knock down TTR that have been studied primarily for neuropathy, but they'll be ongoing in new trials. So it's really an exciting time where we've taken it out from the academic to the real world. We need to know what this is. We still don't have approved therapies specifically for cardiac involvement, but that will be coming in new clinical trials as well.
Well, Dr. Grogan, Dr. Abou Ezzeddine, thank you so much for your important insights on this topic, and thank you for joining us on theheart.org on Medscape Cardiology.